The following podcast is part of a certified educational activity titled Adopting Modern Management Strategies for Obesity, Treating the Patient, Not the Disease. Access the entire activity and complete the post-test at peerview.com/RFR860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Donna Ryan, and I'm Professor Emerita at the Pennington Biomedical Research Center in Baton Rouge, Louisiana. That's a part of Louisiana State University. Welcome to Adopting Modern Management Strategies for Obesity, Treating the Patient, Not the Disease. Joining me today is my colleague, Dr. Carl LaRue, the Chair of Chemical Pathology at University College Dublin, National Maternity Hospital, and St. Vincent's Healthcare Group in Dublin, Ireland.
Thank you, Donna.
During this activity, we're also fortunate to have input from Natasha Weiling, a patient living with obesity. Our goals for today are to augment your knowledge of current guidelines and treatments for people with obesity, to equip you with strategies for patient-centered weight management that integrate emerging therapies, and to provide guidance on using shared decision-making to establish realistic long-term treatment goals within multidisciplinary team care. Let's first hear from Natasha and learn about her story.
Well, first, let me introduce myself. My name is Natasha Weiling. I live in the Netherlands. I've been living with overweight and obesity for about 40 years now. It started with a little bit overweight, like 1 or 2 kilograms compared to children of my age when I was about 10 years old. And we went to a school doctor, like every child should go to the school doctor every year and to be examined on your height, your weight, whatever. So the doctor said to my mom, well, your daughter is about 1.5 kilograms too heavy according to the scale, blah, blah, blah. And my mother thought it was really serious. And she forbidden everything in the house, like sweets, candies, biscuits, whatever. And eventually she put me on a diet. And that's where it all started, with the JoJo effect, because every diet works temporarily, but in the end, the kilograms came back with bonus kilos. So that was the start of my fight against the weight. And during puberty, I gained more weight because then you are fighting against your parents, of course. You want to be your own personality. So whatever they say, it's not true. So I started to grow and grow and grow. And in the end, it's making a long story shorter. When I was about 40 years old, I was 50 kilograms too heavy.
We all know that there's a global epidemic of obesity, but what we may not realize how important that global epidemic is in driving ill health among our global population. In an epidemiologic study of obesity that looked at deaths directly attributable to obesity, there are 5 million deaths globally in 2019 that are caused by obesity. And that's a rate of 62.6 per 100,000 population. Now, some of the areas of the world tend to be more affected by this disease burden, not just because they have high rates of obesity, but also because that population is more susceptible to the adverse consequences of obesity. And in the Middle East and North Africa, those are the leading regions for death due to obesity. And in fact, it's double the world statistics. Natasha spoke very well about what it's like to have susceptibility to obesity and to develop increasing body weight across childhood, adolescence, and early adulthood. I think that's such a common pattern for the development of obesity. Why has this occurred at increasing rates in the modern environment? We all, it's an epidemic. It's an increasing number of people who are susceptible to this. Well, I think the conventional wisdom is that genetic susceptibility, when exposed to an obesogenic environment, produces the expression of obesity. But look, obesity has a complex etiology. There are many factors that drive risk for obesity. There are socioeconomic factors, there are psychological factors, There are many factors that drive risk for obesity. The important thing to recognize about obesity, and I think Natasha illustrated this so very well, is that we are judged by our body size, and stigma and discrimination are um, they're huge problems that patients who have obesity face. So, uh, so the way that obesity causes complications and diseases is through those behavioral and mental health complications. It's also through metabolic complications because we know obesity, abnormal body fat, drives risk for cardiovascular disease, drives risk for type 2 diabetes, and many, many other metabolic complications. Just the burden of the excess body fat can drive complications of obesity like gastroesophageal reflux disease or obstructive sleep apnea if there's too much fat obstructing the airway. But all of these things really contribute to the decreased quality of life and social well being of patients who are experiencing obesity. The diagnosis of obesity in the clinic usually begins with a BMI, and the BMI above 30 kilograms per meter squared is defined as obesity according to our ICD codes. But in the clinic, we want to make a clinical diagnosis of obesity. So the BMI is just a screening measure. We move on from there to look at, is there excess abnormal body fat or is this just an increased body size? And then we look at where the body fat is located. So in the clinic, for people who have an elevated BMI, we always do a waist circumference or another measure of body fat. We can do digital anthropometrics. We can do DEXA scanning to determine body fat. So what we're looking for is a medical diagnosis of obesity that is excess body fat that may be associated with health risk. After we determine that there's excess body fat, we want to know how that excess body fat is affecting health. There are many staging systems, but the one I particularly like is the Edmonton Obesity Staging System. And it looks at the complications of obesity that are mental, that are mechanical, and that are metabolic. And then it looks at different stages. For mild disease, it's stage 1. For established comorbidities with moderate symptoms, that's stage 2. For stage 3 is significant limitations, and stage 4 is end stage disease. Now, you know, the Edmonton staging system classification correlates much better than BMI with risk for death. Recently, the Lancet Commission gave us a lot of discussion around how we ought to be thinking about a clinical diagnosis of obesity. So the very first thing that this commission recommends is that we look at that elevated BMI or elevated body weight. So BMI is a screening tool. And then we look for clinical confirmation of abnormal fat mass, that there's excess fat mass. Is there evidence of this? We can usually tell by the waist circumference. And so for some people, bodybuilders or athletes, they may have a large body size. They may have an elevated BMI, but they don't have excess body fat. And so, no, they don't have obesity. And so we would make a note of that in the chart. But for individuals who do have excess fat mass, that's obesity. But after we make a determination that obesity exists, we want to determine if that's clinical obesity or if it's preclinical obesity. Because for clinical obesity, we want to treat those patients more aggressively. For preclinical obesity, we want to prevent ultimate complications for obesity. So there are some people who have healthy obesity. That's preclinical obesity. They may have an elevated BMI, they may have an elevated body fat mass, but they do not have evidence of abnormal risk factors or of other associated diseases. It's important to treat early. In a study of 6,713 children aged 6 to 17 who were offered 1 year or more of obesity treatment and then followed for more than a decade, when these children were compared with the general population, it was easy to see that those individuals who had the best response, either obesity remission or a good response, did much better in terms of rates of diabetes, hypertension, dyslipidemia, and other complications that led to mortality. So there was a direct relationship. A good response to early obesity treatment resulted in, decades later, much improved risk for complications of obesity. We need to not wait. We need to intervene early. And I think our patient, Natasha, sort of brings that point home.
You were always being judged by the size of your body because they think when you are the fatty one, you're not quick enough, you're not athletic, you cannot win the game with the fat guy or the fat girl. So when it came to choose teams or whatever, I was always chosen last. And of course, that's, yeah, you will feel that inside. It will hurt you. You will not say it to your friends or schoolmates, but you will feel the shame and blame because they don't want to pick you. So I felt like I wasn't part of society. I didn't fit in. Like a prison, you stay at home unless you would love to go out and have fun with friends, but you just don't do it because you don't want to be rejected by other people. And the same thing I experienced during my adulthood with application for jobs. It was hard because every time there were like several people asking for this job, and they don't say it in your face like we didn't choose you because you are fat. But there was one example. I've been there for 3 interviews, even did like a psychological test and assessments. And then they called me and they said, well, you have a good resume and you have perfect experience. You're the perfect candidate for this job. And we would like to hire you, but you have to do something about your appearance. So I was quite offended by that. Luckily, it was a phone call and I was not there alive. So I said to them, well, let me think about this and I will call you back. And as soon as I dropped the phone, I was started to cry like, oh my God, not again. I'm applying for a job in an office, like an administrative job, not like a model. And it still gets me to the throat now if I think about it. So I called them back in about 2 days later. And I said to them, you can keep this job where the sun doesn't shine, because if you shame and blame like this, I don't want to work for you. So I felt quite strong at that moment, but it still hurted. And it's a continuing story in the life when you're living in a bigger body.
Now let's talk about obesity stigma, self-blame, and internalization of weight bias. Unfortunately, in cultures around the world, patients with large body size are stigmatized, and individuals with obesity are believed within that society to have negative attributes. The ultimate cause of this is the failure to understand what obesity actually is, to understand that obesity is a disease and that it is very difficult to lose weight with lifestyle intervention. And it's even more difficult after losing weight successfully to keep that weight off. So our society judges patients with obesity, and that's a bad thing. What that leads to patients with obesity internalizing that, and patients may judge themselves, and that's a bad thing too. Now let's talk about perceptions, behaviors, and barriers to effective obesity care. The Action IO study was conducted in 11 countries across 5 continents and included over 14,000 persons with obesity and almost 2,800 healthcare providers. And what it showed is that patients with obesity tended to delay bringing the topic up with their physician. And on average, it took 6 years for them to bring it up. They also expected the physician or the healthcare provider to bring the topic up. And 68% endorsed that it was the responsibility of the healthcare provider to do this. In turn, healthcare providers viewed persons with obesity as as having low motivation, and this was a barrier to effective weight loss. So these are our barriers. Now, when you talk to the healthcare providers, those who were experts in obesity care, who have been trained in obesity care, who were comfortable discussing weight, who had registered the diagnosis on the patient's chart, and who believed that their patients were capable of losing weight, were much more likely to undertake weight management in their patients. And in turn, patients who were motivated turned out to be comfortable discussing weight with their healthcare providers, were more confident that they could succeed, and considered the healthcare providers a source of intervention. So, this gives us some strategies for what we need to do to help patients and providers get together on their weight loss journey. So, this is the 3D approach: discussion, diagnosis, and direction. So, healthcare providers should discuss the topic with their patient. They should record the diagnosis in the chart and discuss the diagnosis with the patient, explain BMI, and explain how we determine that there's excess body fat and how we stage people with obesity, and direction. Healthcare providers have a responsibility to provide help for patients with obesity. Here's variation 1. What if this is the patient's initial visit with you? And before we go into our first case variation, let's go back to Natasha and see how her treatment journey began.
So when I visited my home doctor for the several times, I went to her with like a fungus infection. And she said to me, okay, I can see in your files that you've been with me for this infection several times. And I prescribed antibiotics and it will work for a few weeks. But I think there's something underlying which affects your funguses, or it comes back every time. So she says, I think you have diabetics. And are you sure you have symptoms of diabetics or not? I said, no, I'm not aware. And she said, well, first, I think we have to figure that out before I give you antibiotics again. And if it's not, if it's diabetics, I should not give you the antibiotics. We should treat your diabetics. So I agreed. She took the blood, and within a day, she called me, and my HB, whatever, the blood values was sky high. So she said, I want you to come into my office within 24 hours because you need to go on medication because you're a ticking time bomb. So I felt quite scared with this message. So I went to her and had a conversation with her. And she said, well, you're officially diagnosed with diabetes type 2 now. And we can treat that with 2 kinds of medications. But I think you can do something about it yourself, and you might not need medication for the rest of your life. It has to do something with your body size, your weight. Are you fine if we are talking about your weight? Because I know this is the struggle of your life. I've been following you for 30 years. I know what you did. I know it's hard for you, and every time you succeed with a diet and then you get extra bonus kilos. So I know you are willing to do something about it, but you just can't because obesity is a chronic disease. It's not your fault. So for me, it was very good that she asked for permission to talk about my weight, because in the 30 years before, I've been to her office, and every time when she started about the weight, I felt quite offended. Like, I'm not coming here for my weight, I'm coming here for another problem. So this was, I think, the best point for her to talk about the weight and about the relationship to diabetics type 2. And she explained me, if you lose a lot of weight, your diabetics type 2 can go into remission and you don't need medication anymore. So I know your struggles and I know there is something that would really be helpful for you, but I want you to take it into consideration. It's not a decision you will make in 10 seconds. But nowadays there is an option of gastric bypass surgery. So then she started to talk about that, advised me to find information in hospital, talk about my friends, family, husband. And she asked me to make a new appointment in another 2 weeks to talk about that together. So for me, I felt like she's taking my problem serious. She knows it's hard for me. She asked permission to talk about it. So I was open to think about it and to consider surgery. And the medication could help me, but it's not available for me because it's just available for just about a year, and I wish I could get them because gastric bypass surgery is not the easy way, the quick fix.
Here's our first office visit for Sarah. Her BMI is 33.1. She's 5 feet 4 inches tall and weighs 193 pounds or 87.5 kilograms. There's her weight history. She's tried many diets since graduating college, but regained weight after each attempt. She has a history of 5 self directed attempts at weight loss in the last 12 years. And she has a particular history of weight retention after pregnancies. In her first pregnancy, she gained 27 kilos and lost 18 kilos. So, weight retention. In her second pregnancy, she gained 32 kilos and lost 14 kilos. Weight retention. She's embarrassed by her weight. She experienced weight stigma. She's overheard her coworkers call her lazy. Here's how and why to obtain a weight history. A good tool is the OPQRST mnemonic. We want to know the onset of obesity. We want to know the precipitating factors. We want to know the quality of life issues around the patient's obesity. We want to know what remedies the patient's tried, in what setting did the patient gain weight, and what's the temporal pattern of weight gain. So Sarah has filled out a life graph. We like to use this because it shows us the history of the patient's weight gain, the drivers of weight gain, post-pregnancy retention, and the overall trajectory of weight gain. And Sarah has a very typical pattern of gaining weight over early adulthood. So I think the very first thing, if we're going to address stigma, and the stigma this patient has reported experiencing, is that we really need to understand what obesity is and to understand the biology of obesity. When we try to lose weight, when we try to create negative energy balance by restricting caloric intake and by increasing physical activity, when we start to lose weight, our body responds. And there are neurobiological changes, both in appetite and in metabolic rate. So when we undergo a diet, the body reacts. The body reacts in a starvation mechanism. And so there can be disruption of appetite regulation, more hunger, less satisfaction with the foods we eat, increased craving, and that results in overeating. And all of this drives weight regain. That's why weight loss is difficult and weight regain is so common. It's important to understand the biology of this because what this means is that it's not about willpower and it's not about trying harder with more resolve. It is not a character flaw. It is the body's biology that is fighting this. We need to understand this if we're going to address our own stigma and bias, and our patients need to understand it if they're going to get out of the self blame game. So when the very first time you meet a patient, I think it's so important that we ask permission. This is easy. Is now a good time to discuss how your weight and health can be affecting each other and how we can work together on it? That's easy, right? Well, what if the patient says no? No, my mother just had a stroke and I'm her primary caregiver. I don't have time for this. Well, your response should be, I understand completely. Look, we're going to table this for now. I want you to know I'm worried about how your weight's affecting your health. Your blood pressure's up. Your A1C is rising. I want you to agree to this. And at your next visit, we're going to raise this again. And if it is a good time, we can talk about making some changes. And then if the patient agrees to a discussion of weight and weight management, then you're off on a journey. And that journey requires 5 A's. So the 5 A's approach came from smoking cessation counseling. And the very first principle we've already done, ask permission. Then to assess the weight history. On to advise, the third A. You're going to advise on diet, exercise, uh, potential for medication, surgery, and other treatments. Then agree on goals. It's important to recognize that the patient has to make these changes, not you. So it's a shared decision about the treatment plan. And then finally, assist the patient by identifying barriers for success and drivers of weight regain. What you're trying to do is not be prescriptive, not be parental. You're trying to be a coach and to use motivational techniques. So there's a technique called motivational interviewing that was actually derived from behavioral counseling in people with alcohol and substance abuse disorders. And what it requires is a coaching technique that uses four key skills. This is the OARS technique. O for asking open-ended questions, not yes, no questions. Affirmation. If you find one thing that the patient is doing good, you pull that out and affirm it. Reflective listening. You listen to the patient and you reflect back to the patient. You mirror what the patient has said so that the patient sees it again for themselves. And finally, you sort of continuously sum up what's going on in the conversation you're having with the patient. I heard you say this, and is that right? And you say you're going to do, is that right? And so it's a way of engaging the patient and making the patient responsible for the treatment. There are lots of approaches to obesity, but foundational is diet and physical activity. You know, a healthier diet and increased physical activity that improves fitness, those have benefits on their own, but they're also very helpful in promoting weight loss. Unfortunately, just a recommendation around diet and physical activity doesn't usually work in medical practice. We can up our game by using a multi component intensive behavioral intervention. This is like a multiple sessions of skills training, or even adding to that some tools um, such as time restricted eating or meal replacements. For patients who do not succeed with lifestyle intervention, we move to pharmacotherapy and then sometimes endoscopic procedures and bariatric surgery. The idea here is that as patients have increased health risks associated with their obesity, we use these more aggressive techniques. It's like everything else in medicine. You know, for patients who have the greatest health risk, we give treatments that also have some risk associated with them. But for patients who have little health risk, we give treatments that have little health risk associated with them. What clinical testing would you utilize to recognize and diagnose obesity in a patient on the first office visit? We start with the BMI. If the BMI is above 25, I want to know, does that patient have excess abnormal body fat? That's obesity. And so I want to know what the waist circumference is. I want to know if the patient's a bodybuilder. If the patient's BMI is over 35, I know that patient has obesity. It's in between 25 and 35 that you really want to do the waist circumference, obtain a DEXA in some instances, a bioimpedance in other instances, or even digital anthropometry. That helps you determine if the patient has excess abnormal body fat. We use patient-centered language, putting the patients first. It's a person with obesity, not an obese person, all of the time, because it's more respectful. A patient should not be defined by their disease. Um, in fact, I don't often use the word obesity in dealing with patients. Patients don't really like that word. They find it itself stigmatizing. So I'll talk about body weight, I'll talk about BMI, but I always link it to health. It's always about how your body weight is affecting your diabetes, how your body weight is affecting your obstructive sleep apnea. So I don't really use the word obesity a lot because I think that really helps put patients at ease.
So, what if this is a follow up visit after the patient had insufficient loss on lifestyle modifications alone and anti obesity medications, is considered? But before we get into our second patient case, let's hear Natasha's experience with lifestyle modifications.
Well, during my lifetime, since I was 10 or something till my 40th, I've tried a lot of diets before the doctor came up with gastric bypass surgery. So it worked during the diet, but afterwards, when you return to your old pattern, the weight regains again. I've been to, of course, to the gym with like a dietitian and a personal trainer to try to change the lifestyle. And I even went when I was a child, I was 12 years old, to an obesity clinic where they tried to teach us how to incorporate physical activities in your life, what is healthy food, don't eat snacks, all that kind of stuff. And of course, I did like the calorie counting. You cannot imagine what I didn't try. So, and what I say, they all work for a few weeks or months, and when you start to come back to your old routines, the weight will regain.
So here we have a patient that had a BMI of 33, came down to a BMI of 32.4. The weight came down, and she's had more than 5 self-directed attempts, at weight loss over a period of 12 years. And every time she felt that she should be able to reduce her weight. But unfortunately, every time she tries, it comes back. And very often she's actually a little bit heavier than she were before she started. So this patient is disappointed with the effort. She thinks it's her fault. She's asking you, what has she done wrong? And this is an important time for us to think, how can we actually do better? Now, I think the first thing is to realize and to understand the biology. That very often a eating less, moving more approach is not a treatment for the disease of obesity. And we see that because patients can lose substantial amounts of weight, but it doesn't treat the disease, and therefore they are not able to maintain the weight loss in the long term. So this is normal biology, and this is what the evidence base is showing us if we look at really great studies that's been done in a randomized controlled way. Now, let's compare and contrast that with medication trials. Here I'm showing you phase 3 trial data, and you can look across, even from orlistat, the combination of phentermine to pyramate, combination of naltrexone, bupropion, liraglutide, semaglutide, tirzepatide, and we compare that with other good obesity treatments such as sleeve gastrectomy or gastric bypass. And what you see here is that as long as the treatment is continued, you can actually maintain the benefit because these are obesity treatment. They're not weight loss treatments. Now, you can see that some are more effective than others. Bariatric surgery is an effective obesity treatment, but we also can see that medications such as semaglutide and tirzepatide are closing the gap. But we should not forget about those other treatments that we've had for a long time because we also have very good safety data on them. And it's when we look at the long term safety data, it's important for us to understand that this is going to convince many of our patients to engage in treatment or not. And it's reassuring that we have such long term safety data, and understanding the mechanism of action allows me and you to explain to our patients how these medications work, but also, more importantly, what are the side effects that we may expect. And it's demystifying this and reassuring patients that whatever happens to them, we have seen and we are able to manage. And I think that reassures patients, but also reassures you as a practitioner because you can actually understand this is biology, that these side effects are not random events, but they are biological events that we can understand, we can anticipate, and therefore we are much better at dealing with. Now, if we think about how can we consider future individualization of anti-obesity medications, then it comes down to having the most effective titration schedule, and how can we titrate these medications and reduce the side effects of this. And that's something that many of us are doing in clinic, where we are reducing the rate of titration to reduce the side effects that we have. Now, that's specifically very common with the GLP-1 based treatments, because the GLP-1 and GIP, GLP-1 based treatments, we can see a significant number of GI effects that's very often associated with where you initiate the dose and how quickly you titrate the dose. So, therefore, helping patients to eat smaller portions, lower fat foods, that helps, but also knowing that we can actually slow the titration down when needed also play a very important part in helping our patients. So, if I think about what are the recommendation and recommended treatments that I would like to initiate in patients to meet their individual treatment goals, I know I have nutritional therapies, I have exercise therapies, I have pharmacotherapies, and I have surgical therapies. All of these options remain on the table, and therefore explaining the long term outcomes from an obesity treatment point of view, but also the side effects of these different interventions will help you and your patient make better decisions. And then, how can I include the patient in clinical decision making? I think this is about providing information. We do have a biological understanding of our treatments now, not only how effective they are, not only why they work, but also what side effects they may have. And being able to explain to patients in equipoise, even if we just think about the pharmacotherapy options, some options have much better weight loss, but may have less data when it comes to the long term effects on the cardiovascular system, for example. Other treatments may have less weight loss, but are very rich in showing reductions in cardiovascular events or even reductions in developing diabetes, etc. And therefore, having our patients make an informed decision not only about weight loss, but about long term health gain is why treating patients with obesity is now so enjoyable, because we have these options that we can really practice best medicine.
Our next variation, variation number 3, what if a patient initiated a weight management plan and wants to know more information on next steps and when to expect visible improvements? But before we explore this topic, let's hear how Natasha's healthcare team set expectations for her treatment.
Well, during the period that I was going in through my gastric bypass surgery, uh, there was like an intake conversation with my home doctor. She referred me to the hospital, and they were preparing us on what it means to get a gastric bypass surgery, not only the technical stuff like where are we going to cut and whatever, but also like what does it mean for change of your lifestyle, because you cannot eat everything after surgery, and you have to learn to eat again because you are starting with a stomach that's the size of a kiwi. So the reaction of your body that can change from people to people. So that's what they prepared you for, that you could have like dumping syndrome or whatever, and how to prepare for that, because it can feel like you are getting sick within 2 minutes, and you get a very high heart rate. So you might think that you are dying, but it's not. And they prepared you like, well, you might lose about 30 to 40% of your weight, but it's not a fixed number. It depends on different factors. So they didn't give me an exact number, of course. And I was happy that they didn't give me the exact number, because they figured out that I would lose about 30 kilograms. And for me, that wouldn't have been enough to say yes to the surgery. Luckily, in the end, I lost 50 kilograms. So I was very happy they didn't tell me their predictions.
Sarah's looking for more information after initiating an anti obesity medication. She was in your office 6 weeks ago and you started her on an injectable anti obesity medication. She calls your office due to worries that the anti obesity medication isn't working. She skipped last week's dose because she's feeling queasy after dinner. That was the week 5 dose. Okay, here's what we can expect with our obesity medications. Our older medications, like liraglutide, shown on the left, produced much weight loss than the newer medications, semaglutide and tirzepatide, on the right. But what I want you to notice about this is that with our older medications, there's a plateau that occurs fairly early, after about 6 weeks, and then we see this dose-related plateauing of weight after that, out to a year in this study. But with semaglutide, look, there's a very long weight loss period, out just slightly beyond a year before the plateau occurs. This is also true for tirzepatide, and you see the dose effect there for the 5, 10, and 15 milligrams. So for our patient is in the dose escalation period. We start low and we go slow. So we're starting with just 0.25 milligrams of semaglutide or 2.5 milligrams of tirzepatide. We know when we start these medicines, we're going to get some nausea and vomiting, especially after the dose is given within the first 2 days of the dosing, and then when the doses are escalated. So I'm not surprised at all at week 5, when Sarah went up on the dose, that she had some queasiness after a meal. These medications delay gastric emptying, and so the nausea may be associated with that. So the thing to tell Sarah is that we need to go slow on our dose escalation, but you need to anticipate that side effects may occur. And so I'm going to give you some information about nausea and vomiting with your medication that are going to help you choose your foods and have a better strategy for eating around that. But I think we need to go up to that escalation dose and continue it weekly. If you do have nausea again or have vomiting, give me a call and let me know. It's not unusual at all to have some queasiness. You can use over the counter medications, but I think changing your diet a little bit will help you. The other thing that patients need to know is that not everyone has the same effect of these medications. We talk a lot about mean weight loss or average weight loss, but we don't have any average patients. And these waterfall plots illustrate that. So if you look at tirzepatide on the left and semaglutide on the right, each person's weight change is shown by one bar, and we see this huge variation. Some patients are losing a lot of weight. Some patients are not losing very much weight at all. With tirzepatide, almost everyone is achieving at least 5% weight loss, and that for many patients that can be quite efficacious. But these larger amount of weight loss are not a guarantee with the patients, and we need to let patients know that. So so what we do is we like to keep patients going on the drugs and trying to get the dose up to the top. Because if we can get patients to the top doses, we're more likely to get that 10% weight loss, that 15% weight loss, which is associated with greater health improvements. So go slow, start low, but be diligent. Stay on the dose. The other important thing that patients need to know is what happens when you stop the medication. We know this about all anti-obesity medications. There's an initial weight loss period, there's a plateau period. As long as the medication is continued, the weight loss will be maintained. If the medication is stopped, we see an increase in weight in the population. We do not know if some individuals are able to stop these medications and succeed with weight loss or not. What we do know is if they stay on the medication, they are very likely to sustain the weight loss. This is true whether you're treating obesity, diabetes, hypertension, dyslipidemia. You must take the medication for it to work. So, percent weight loss or the amount of weight loss is not the only reason that patients should be managed for their weight. And that's why I liked asking about what's that single most important outcome. I know that different amounts of weight loss have different effects on blood pressure, on lipids, on glycemia. And so I'm often treating patients to improve diabetes, hypertension, dyslipidemia, cardiovascular risk, obstructive sleep apnea. But sometimes patients have desires with their weight loss journey about improving quality of life, about getting down on the floor with their grandchildren, about having better sleep quality, about feeling better about themselves. These are all perfectly good uh, things to follow in our patient, and we need to be patient centered in our assessment of outcomes. It's not only what I want, it's about what the patient wants too. Here's some questions. If the patient is using a GLP-1 or a GLP-1 GIP receptor agonist, how do we address the patient's concerns about the GI effects of this drug? Fortunately, we have a practice aid available for you. There are some really great tips on it. We need to watch what we're eating. We need to watch how we're eating. We need to watch what we're drinking. We need to anticipate these GI side effects because they are an on target effect of the drug. These medications delay gastric emptying, and that can be associated with GI side effects, and we need to be aware of them, and we need to do what we can to manage them. How do we set weight loss expectations for this patient? I think the most important thing to to do with the patient is to say at the outset, we're going to start you on a journey with a low dose of this medicine. We're going to increase every month and try to get the dose up to one that has the optimal effect for you. It's going to be a personalized dose. And we're going to make that dose escalation schedule starting low and going slowly to try to avoid as many side effects as we can while still achieving appetite effects that improve weight loss. So I can't predict in advance how much weight you will lose, but I can tell you I'll be on this journey with you and I'll be advising you about how to increase your dose and how to manage side effects.
So, what if the patient also has binge eating disorder? Now, with any patients who has multiple comorbidities, a comprehensive healthcare team is essential. So let's first hear how Natasha's multidisciplinary team supported her.
And during the whole process of my gastric bypass surgery, there were several healthcare professionals surrounding me for help and education on the new lifestyle. So it started with my home doctor, and then she referred me to the hospital where I met the surgeon, the dietitian, the psychologist, the internal doctor, and the physician assistant. And they all had their own part of the new lifestyle, which they were talking about with me to prepare me for my new lifestyle. And they said, if there's any day or whatever, when you have doubts about what you're doing is okay or not, or you're feeling not very well, or you're having trouble, just call the physician assistant. She's the first one to call. And she will look which of the healthcare professionals is able to help you. And that was very helpful because she just had one phone number, one person to talk to, and she would make sure that the right people got into contact with me to solve my problem or to answer my questions. And they all worked on the same department in the hospital. So if I came there for my checkup, I could see all the familiar faces again. And what was very helpful was that they had a special department in the hospital for the obesity treatment. So if you would sit there in the waiting room, the chairs would fit. And if you would compare that to like the urologist, there would be like normal chairs, and you would feel like, I don't fit here. And people would look at you because the chair will not fit your arms, and you wouldn't feel happy. It's already a difficult subject to talk about, and then you're in your waiting room confronted with the size of your own body. So that was very helpful that there was a special department and everything was fit to bigger people, from chairs to the blood pressure band, everything. There was no bumps. You just felt like a normal person. My advice to healthcare professionals would be, when they are taking care of people living with obesity, treat them as people and not as a number on the list of tasks to do on that day. Be empathetic and try to listen to their story and bend with them and show them that you understand that it is difficult. It's a lifetime chronic disease, and it's very easy to judge from the outside, but you don't know what's inside of the people, what they have been experienced during their lifetime, during their struggles. So that would be my main goal. Just treat them like every other patient and not like a bigger patient.
So let's return to Sarah's case and a binge eating disorder diagnosis that's being made. So here we have, you'll remember that she had a BMI of 33 to start, came down to BMI of 32, then tried, other medications, and now we're back with a BMI of 33. So we can see how the weight has come up and down. And thinking about her history, she tells us that she stopped the obesity medication over the holidays so she could enjoy some big family dinners. She gained 3.5 kilograms in the last month. And she's had multiple binge eating episodes in the last month. Now, she's angry with herself because of the weight regain because of the prior successes she's had. And she's really feeling disgusted with herself when she overeats. Now, that is something that we hear very frequently in clinic. And, we must have sympathy with our patients because it's a difficult situation. And when we try to measure this, you could see that the variation, of binge eating disorder, whether or not you look at subclinical binge eating disorder or binge eating disorder before bariatric interventions or surgical interventions, vary dramatically from 2% up to 64%. So it does little bit matter how you do measure it. Some of the scales are very sensitive. Of course, an interview that's very often required to make a DSM-5 criteria definition, is more sensitive and specific. But we need to differentiate binge eating disorder, the diagnosis that is characterized by recurrent binge eating, psychiatric comorbidity, and overvaluation of the body. And we need to differentiate this from depressive or bipolar disorders, borderline personality disorders, anxiety disorders, or bulimia nervosa. So important that we see our patient holistically and we understand that these mental illnesses can coexist with other disorders and diseases. So people could have hypertension and they could have any or all of these. So don't always link this with the disease of obesity. Understand that it can actually coexist. And it's a complex issue. And therefore, we need to use our clinical acumen to make a diagnosis and work out what we want to treat. But if you think about how we can break this cycle of binge eating disorder, then we also need to understand these four big phases, where we first have, if we start maybe at sort of the 1 o'clock position on the clock, you would have the patient feels that they are binging, it's not working for them, it's an unsustainable situation that they are in. This generates the next phase of guilt and shame. There's more emotional dysregulation of our patient. And then we have this ability where the patients are trying to cope. They have another attempt. They're trying to address their feelings. And then you have this issue where people restrict themselves. They have a desire to feel in control, but yet they are being overwhelmed by emotions, which very often trigger the next phase again, of the binge. And the patients go round and round, in the circle. And it's difficult for patients. And every time they go through these processes, they have like a deja vu experience. They remember that they were here before, and that also reduces their enthusiasm and their confidence that they can break this cycle. So you need to understand where the patient is in this cycle so that you can make a diagnosis, you can reassure them, you can counsel them to understand that this is biology and we can address this in a biological way, because these symptoms that then is generating the binge eating episodes are very often driven by biology, by understanding the brain and understanding how we can interact with this. But there's a step system of care for eating disorders. And the principles are that we need to understand the guidelines that we have, the lived experience, and of course, understand what research has been involved. And we need to involve not only the person, but also their family members, their support, their community, so that we can go through these processes of preventing it, identifying it, and having an initial response. And ultimately, we have different options. We can have community based treatments, we can have community based intensive treatments. And then, of course, we also have hospital and residential treatments. But it's the psychosocial recovery and support that we have to be able to provide to our patients to again drive this health gain overall for those that we care for. And we need to be able to reassure our patients that healthful eating can be appealing. Now, this is about nutritious foods can also be filling because in many of our patients, the problem is triggered by hunger. And if you therefore have increased appetitive behavior, you are thinking about food all the time. One way to break that cycle is to actually give people food and treatments that makes them feel less hungry, that reduces appetitive behavior. And therefore, nutritious foods, vegetables, fruits, can occupy actually more room, not only from a space point of view, but is also better at signaling from the gut to the brain to allow the hunger to reduce. And very often, plant based foods take longer to digest, and therefore it sends more signal from the gut to the brain. So, what we want is our patients to eat healthier, not necessarily from a weight loss point of view, but we want to get them good nutrition that actually sends a stronger signal from the gut to the brain for them to feel less hungry, more satisfied, and also for them to enjoy this. Important that they cannot eat foods that they don't like. And we have to actually give this in the long term. So, therefore, thinking also about pharmacotherapy, and here we can think about lisdexamfetamine is one of the only medications that's approved for binge eating disorder. But we can also now see other treatments such as sertraline, fluoxetine, topiramate, as well as the GLP-1 receptor analogs, and how that can work. And looking on the right, we can see that these treatments very often work inside the hypothalamus on the POMC NPY neurons that increases satiety and reduces hunger, that allows the patient to have this reduction in appetitive behavior. Now let's look at studies when we actually just use amphetamines and topiramate, and we can see a reduction in binge eating scale of 5.9 points. But we also see that's associated with a weight loss of maybe 13 pounds, so for a 5% weight loss. Now look at semaglutide on its own, we can see a binge eating score reducing by 14 points and a weight loss of 8.7%. And then, unsurprising, let's look when we combine our approaches. Semaglutide plus minus amphetamines or topiramate. And now we can see a binge eating score reducing by almost 13 points, but then the weight loss being closer to 16%. So here we can see how if we can reduce what's happening inside the brain that very often drives our binge eating disorders, we can not only reduce the symptoms of binge eating, but we can also have health gains from a weight loss. But we can only achieve this if the care team for eating disorders put the patient in the middle. And of course, we surround them with family supports and community supports. And then we also have our medical practitioners and mental health professionals in support. And ultimately, we also have our multidisciplinary team with dietitians, psychologists, psychiatrists, and actually helping support our patients. This is a very straightforward model that we use in multiple other chronic diseases. And therefore, we don't have to reinvent the wheel. We can replicate what we knows work well for our patients. So if I think about How can, I implement lifestyle modifications without triggering disordered eating behaviors? Then what I want to do is I want to give nutritious foods that will allow our patients to feel less hungry. These foods are not necessarily there to make them just lose weight, but to get health gains, to take away the appetitive behavior that patients very often refer to as food noise. And I also want to think, what other members of the multidisciplinary team do I want to actively involve in the patient care? And that allows me to think about, where are we in this patient journey? Can I, as a practitioner, with the help of the patient's family or support structures, is that good enough? Or do I need to escalate the intensity of the care and involve my multidisciplinary colleagues, such as our dietitians, psychologists, psychiatrists? And that often is necessary, but we have the infrastructures and we are able to do this in the long term to the benefit of our patients.
Dr. LaRue and I have covered a lot of important topics today. Let me summarize the key takeaways for you. Obesity results from many factors that are not under volitional control, and not all persons with obesity require pharmacotherapy to attain their individualized health goals. Obesity is a stigmatized disease. Always ask permission before discussing weight management. Do not assume that you know what the person with obesity prioritizes. Ask them what their single most important outcome is. Achieving beneficial amounts of weight loss with anti obesity medications may be attained in a few months. Disease modifying levels of weight loss may require a year or more. Binge eating is prevalent among persons with obesity and may respond well to anti obesity medications, although further research is needed in this area. That ends our presentation today. I'd like to thank my co-chair, Dr. LaRue, for an excellent discussion, and Natasha for contributing her perspective on this. Natasha, you were magnificent. Thank you.
Donna, thank you very much. That's been such a pleasure to work with you again and, really trying to get these messages across by how we can improve the health of our patients with our various interventions. Thank you.
I hope you found this activity informative and helpful in treating people with obesity. I encourage you to download the practice aids and slides from the menu on the left side of the screen.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/RFR860.